I reworked this didactic quite a bit from the last time. So the last time I did this didactic on behavioral interventions for hallucinations, I tried to really have it be comprehensive and to really walk people through the range of behavioral interventions that you have in your toolkit for auditory hallucinations mostly. And this time I wanted to just go a little bit deeper rather than covering the breadth of interventions, to dive deeper on two important interventions for voices. So one of them is behavioral activation, and that's the one that we'll cover in depth today. And then the second one is exposure, which we'll cover in depth on our next clinic on July 8th. So just want to give credit because this didactic was an adaptation of a behavioral activation for depression didactic that was developed by two professors in our department, Carrie Stevens and Patrick Rowie, and they developed that with funding from the Washington State Department of Labor and Industries. And so I made adaptations so that it would apply to individuals with psychotic symptoms. And so this slide shows our learning objectives for today. The first is to really understand the behavioral activation model of both depression and psychotic symptoms. And I left depression in there because, we really think about depression and demoralization as part and parcel of schizophrenia. It might not be manifesting during an acute episode. Certainly we know that when people have poor awareness of insight, that tends to dampen the depressive symptoms. But we also know that awareness of illness is dynamic, and as is depressed mood. So it's really important that we are applying behavioral activation really as a rule for all of our clients that we're treating. So the second is we'll describe how to develop a case formulation or a mini formulation for a client who's experiencing elevated depressive symptoms and psychotic symptoms. We will talk about the role of avoidance in maintaining psychiatric symptoms just across the board. In CBT, that behaviors, we're not just concerned with behavioral excesses like cutting, yelling at the voices, impulsive addictive behaviors, but also behavioral deficits and avoidance, isolation. That is our most common types of behavioral deficit. And then describe how to help clients select activities and make a specific weekly plan, really setting people up for success. And lastly, to understand how to evaluate the outcome of patients' efforts and to problem solve barriers to action planning. Okay, so you guys know right now that a good CBT therapist always, before you introduce a skill, you always explain the rationale and you tailor that rationale for the individual. And so if I were to provide a rationale for behavioral activation in a way that you could say it to your clients, I would say two things. One is, simply put, the more you do, the better you feel. And second, again, simply put, behavioral activation is our best antipsychotic. It doesn't replace medication, but this is something that is universally helpful for people, whether they're struggling with poor sleep, depressed mood, negative symptoms, or positive symptoms. BA doesn't just increase the number of pro-social, energizing, pleasurable activities, but it also targets patterns of avoidance, withdrawal, and inactivity that keep people stuck in distress and dysfunction. BA is a structured approach, so it's not spaghetti throwing, as we've talked about. But that being said, within behavioral activation, there will likely be some trial and error. But it does happen within a weekly plan. You're giving something a fair shot, you're troubleshooting, and really the goal here is long-term sustainment. And I'll say more about that at the very end of this presentation. But we're not just trying to get them involved in activities simply for the sake of doing it. We really want to start to build towards something that will be part of a life that, that's sort of integrated within the community. It is brief and easy to use. I will say BA is one of those interventions that is deceptively simple. It seems very intuitive and easy to use, but for those of us who have tried to help our clients with negative symptoms or social anxiety to break out of those patterns, then we know it is not that easy, right? So that's what this didactic is all about. And then BA helps people to improve their mood. And what we're trying to do, where the cognitive therapy comes in, is that we're trying to use that shift in emotion to help to shift beliefs about themselves, other people, and the world. And that is critical to any good behavioral activation. Okay, so this slide shows the 3 goals of behavioral activation. The first goal is to help patients increase adaptive activities to improve their functioning, and preferably we always want to be looking for activities that are going to increase mastery and pleasure, and also that will hopefully be goal or value consistent, right? And I think a lot of that work at the beginning is to establish what are people's values, what do they value, what do they want in their life, not just their goals, but their values, and then to try to make sure that your BA is responsive to those values. The second goal, which you can kind of think of as the other side of the same coin, is to decrease activities that maintain depressive psychotic symptoms, right? So these could be things that are, avoidance, sitting around the house, ruminating, perseverating, isolating, not telling other people about what's going on, that oftentimes we need to be able to talk to our clients about both decreasing those activities and then increasing their adaptive activities. And then a third goal is to help clients problem solve barriers to accomplishing these important or rewarding activities. And this really comes into play when we help clients to create their weekly plans for specific activities and to help them think through what might get in the way and what would you do when this comes up or if this comes up. And also, this is a fantastic opportunity to bring in other members of the clinical team to help, with these barriers, and or to bring in members of their natural support system to really make a well thought out plan. Okay. So our 4 steps of behavioral activation. The first is explaining the model, just very simply put, in the way that I said it a couple of slides ago. We know that this tends to be one of the best, most effective antipsychotics. It doesn't have, there are no kind of negative side effects, and only kind of positive things that we tend to notice, or neutral that we tend to notice. And, this is really about kind of asking you to go a little bit outside of your comfort zone in order to get some long-term relief from some of these things that have been bothering you. And then we ask a lot of questions, and a lot of this you've probably done, but given that BA is one of our first strategies that we tend to use with folks, it's possible that you might be starting behavioral activation towards the end of the assessment phase or the beginning of the intervention phase. And so those questions that we ask are really to help us understand what are they doing now, and what are they doing that's maintaining the distress, and what are they doing that is helping, that's active, and then what can I, if I think about this as like a fear hierarchy, what would be the next step up, so that you really have a good strategy and if I'm going to do this low and slow, what's the next thing? Then you will collaboratively select your behavioral activation targets and make a plan, and then follow up. So you want to evaluate the outcome, problem solve barriers, and really try to make sure that you're checking in to promote long-term continuation, that they're sustaining themselves. When we explain the model, obviously the way that you explain this will be based on what they're identifying as most problematic. So for some people, it's depression or lack of energy, or the voices. any of those can fit in easily to this model. Essentially what the model is this is simplified, right? So we're not using our typical triangle here. We've taken out the thoughts. We're simply trying to hammer home that when we do less or avoid things, that in the immediate term, we feel relief, we feel, maybe calm or euthymic, but in the long term, we end up feeling bad. And you can ask them for specific examples here. You can self-disclose an example, or you can use an example that they've already shared with you and just kind of fit that into the model. And then if we're looking at that for, how this model can be turned on its head, the way the BA model really helps is we're going to kind of work on feeling better and doing more. So we're going to first do more and then start to feel better. And that's not how most people want to do this, right? Most people tell us, I don't feel like it. I'll do more when I start to feel better. And we want to actually tell people, we're not going to wait for that internal drive or motivation or mood state to hit. We're actually going to do this outside-in approach. And if you know DBT, you would think of this as opposite action. And it's the times when we most want to retreat or be inactive are the times when we most want to actually get ourselves out there. So we're going to ask you to act according to a plan or a goal rather than that internal feeling state. During that assessment step, we want to find out, what things are, bothering them. Where do you want to go from there? What would help you to have a more meaningful life? So this is all, again, a lot of this is done in your engagement and assessment phase, where you're finding out what are this person's strengths, what are their values, what are their goals, and then what are they doing now, and what's causing them the most distress. So all of that is to help you to develop a formulation that you can then really kind of personalize. So when we take these questions, we're really kind of moving beyond the model by asking them, how this applies to their own lives. And that's all we mean by a case formulation, right? It's really just personalizing this. So for an individual that is experiencing low motivation, low energy, low emotional expression, then oftentimes the way that they feel as a result of that is guilty, worthless. Sometimes there's a lot of shame there. And that can actually make us feel, it can drain us even more of our energy and our internal drive to do things. And so you could do the same. I know we're talking about voices here, but you would do the same thing with paranoia, that you would just model in the immediate sense. I feel relief when I stay home after having paranoid thoughts, but it actually serves to increase the anxiety. And so it's kind of like, just kind of putting yourself out there, even though you're feeling paranoid. I know I hammer this home so much, so this is not going to come as a shock to anybody. But anytime we have an opportunity to do something in the session with a client, it can really enhance buy-in for the client. And remember, whenever we're introducing a new skill, we always want to start with our rationale. We want to then give instructions for the skill, make sure that they understand why we're doing it, how to do it. Then we want to take our SUD rating. How distressed are they by whatever that target is, the voices, the low energy, the sadness. And then we would do it together and then take that SUD rating again and then debrief. And if there's any corrective feedback, just making sure you're doing that, reinforce, then provide the constructive feedback, and then reinforce again. And then if you can bring in a natural support, even better. So this is where I love, if I know that I'm going to be teaching them a new skill or we're going to be doing something active in the session, then I want to see, can I get the loved one to either come in and be available for the last 15 minutes of the session, or to be available by phone so that we can call them. One thing that can be really helpful is just to remind clients that this is just an experiment. It's not about succeeding. It's just about doing it. And just keep in mind that it's not forever. We're just trying something new, making observations like the curious scientists that we are, and then, debriefing. And then we talked about this graded assignments, not graded as in you get an A for this, but graded as in a little at a time, right? We're shaping behavior, and particularly where we have clients that are engaging in a lot of maladaptive behavior or a lot of avoidance, then we want to make sure that we are establishing that baseline and going low and slow so that we can instill self-confidence in everything that we do in CBT and mastery. And then really just reinforcing people. So making sure that we are, that we know our clients well enough to know what's positively reinforcing for them, and that we do positively reinforce when they complete all or some of a behavioral activation. So this is just an example of a brainstorming list. What I like about this list, there's so many out there, but what I like about this one is that it generates a lot of ideas for the client, because oftentimes that can be a stuck point. I had a client with really predominant heavy negative symptoms, and generating the activity list was just, it was just like pulling teeth. And so here's one that's pre-populated, and all they have to do is rate it easy, medium, or hard based on, what are they doing now? How hard would it be for them to do that? Okay, so we covered goal 1. The second piece of this is decreasing those activities that maintain the symptoms. And again, that's going to be part of your formulation, right? So are they sleeping a lot? Are they eating when they're bored? Are they, what are they doing now that you think is really contributing to maintaining the depressive symptoms, or the voices in this case? And then, of course, our step 3 was to problem solve. So in general, this is kind of moving on to step 3. The more specific the plan for BA, the more likely it is that the client will follow through. And if there's accountability based on another person that you've involved in that plan, then you're more likely that the person will complete the plan as well. That's certainly true for me. If I tell somebody I'm going to do something, I'm much more likely to do it than if I just set that goal for myself. So really get nitty gritty, and you guys hopefully are in the habit of using the session assignment and feedback form. And so on that feedback form, it has the days of the week and what are you going to do on each day or on the days that you designate. And then you would just add in the other details. Who are you doing it with? What obstacles could come up? And when those obstacles come up, what are you going to do? And then asking the client, how likely are you to do this? What will you do if you don't feel like doing it? Because we know that that will happen. And what will you do if the voices are really intense when this happens, right? Especially if the BA is out in public, oftentimes that's when our clients are most wanting to remain isolated, is when the voices are really intense. And so what can they do? Can you have a plan where some of their BA might be just independent and they can do it from home, and another BA is out in the community? Okay, I'm going to kind of skip some of these in the interest of time, but that 4th step is evaluating the outcome and problem-solving barriers. And so we will always want to make sure that we are asking about the target behaviors at follow-up meetings. So, Chris, we've been working on the voices. I know you had set a goal of making it out to the Y this week. I'm curious how that went, and I'm really curious to hear, too, what the voices were like before you went, while you were out, and after. Did you write that down? Let's talk about that. I had that down on our agenda first. And then we do want to, of course, hope for the what is it? Plan for the worst, expect the best, or hope for the best, plan for the worst. So our clients might not do the activities. And, you know, we don't want to, we want to make sure that our verbal and nonverbal response to that is non-judgmental, but at the same time, we also are part of that accountability plan, and we did this for a reason, right? We asked them to do this for a reason. And so what got in the way? Did they not really feel like it was actually all that relevant to them, or did they not see how it aligned with their values or goals? Did they simply forget? Or was it too hard? Were they having a lot of thoughts that were getting in the way? And so really taking the time to be curious about this, to not assume that we know what got in the way, to elicit that from the client, and then to respond accordingly. And then finally, I promised I would say something about this at the beginning. Our behavioral activation is our intervention when we're within the treatment course. It's really introducing new activities that can increase mastery and pleasure and reduce their inactivity, reduce their avoidance in the interest of improving their mood and improving the voices. The next kind of piece of that is starting to figure out, well, this was really effective and you enjoyed it. And so how could you make sure that you're doing this? How often do you want to do this? In your recovery life, how often would you see yourself doing this? And then really building towards that recovery lifestyle where the individual is doing the things that he wants and needs to do each day to live a self-defined, meaningful life. So for one of my clients, that was prayer. For another client, that was yoga. For another client, that was a walk, you know, walking every day, just making sure that we are not letting these things go, because this isn't about homework. This isn't about a treatment activity. This is about rebuilding their life step by step.